We have time for a few questions, and I think I'm going to just start taking the progress of being the moderator here. All of these require, and we talked about this morning, the importance of needing data, but also building capacity, and at all these levels, be it in a community and all of the partners that you've brought together. Can you talk or address a little bit strategies you've been able to implement to be able to address the use of data by each of these different partners and how that's come together? Wants to take that.
So with our Thrive Local initiative, all of the community agencies had their own data, and everyone has their own client management system. And so by creating the platform, which is part of our community benefit and investment in the community, we're making it easier and we're meeting everyone where they're at. So this Thrive Local can integrate with our medical record, but also all the community organizations' client management system. And that's what it really took for us, because we knew the data existed, but nobody had access to it all. And so the technology is the way and not requiring people to throw out what they're using, but to work on that integration strategy. And so that, we worked on this for years before we figured out what that technology was to kind of bring that all together. But that's been really helpful because all the data is pretty siloed.
Thank you. Anybody else?
Sure. I think use of data, I think people don't know what they don't know. And so actually as we put in the systems in place, it just highlighted the situation and putting the structures just on how the health outcomes currently are compared to what they aspire to, and those unreached really empowered the clinics and even the patients and those unaffected to really educate themselves and strive for more. And I think it's through this and the realization that and these efforts based on this data now have allowed clinics to provide more quality care, and that's reflected now in also both the increase in primary care centers in their budget and also the payment of their staff, and really reinforcing the system. So.
I'd just like to thank you, Jeff, for mentioning Donald Rumsfeld, the known unknown unknowns, whatever it was. It's really a very important point. 25 years ago, I worked with the Robert Wood Johnson Foundation doing community health assessments in hardship communities, and the first thing that you find out is that the poorest communities can't qualify for physician shortage designation because they don't have the social capital to apply for it. So the question of how you understand what a community is and how communities under stress respond, your point about the homeless, I think is really well taken, because the most vulnerable, generally speaking, if they have any community, as we see, all of us will see when we walk out these doors and see the tents on the street, or have a very tenuous grasp on something called a community. So in our work, I skipped over, because I was in a hurry, the community domain in our vulnerability assessments, but what we try to do is to understand who are the community advocates, and are their responses short-term or long-term, or is this normal coping or calamity coping? Are there models that are scalable? Are they healthy models? Because gangs are a system of community adaptation in the absence of other forms of services or their absence. So I think that it is the key question here, isn't it?
Any question from members of the forum first? Yes.
As a question to Karen, but also, I'm John Monahan with Georgetown University. A question to Karen, but really to everybody is, I got the part about how the technology can build the bridge between the health provider and other service needs, social needs, but is that enough? Because a lot of the other partners, whether they're formal parts of the community or not, I suspect are under-resourced in a lot of the communities. So how does Kaiser take on that step as well, and how did you think about the resource needs of the other, of sort of the non-health providers?
Yeah, I mean, we're very concerned about, kind of stressing the community system by having, it's so easy to refer people. And so, I mean, one of the parts of our community health is investing in those community organizations. So we do have the financial arm, but we also believe by creating this open platform that other systems are going to come on board and also have the need to support these community organizations. With our initial investment in homelessness, we've now seen technology companies say that they're investing. And so we're hoping other industry players are also investing, because we talked about incentives earlier. So Kaiser Permanente, we have incentives. I mean, one, we're required to invest in the community, but we also do better by having a healthier community. Well, all of these companies that are, especially in the Bay Area, they have an incentive. They need employees. They need healthy, productive workers. And so how do we increase the dialogue in our regions so that people are supporting the local community organizations and supporting the overall community?
Yes, please, David.
Just like to, Jeff, did you want to say something?
Go ahead first.
Okay. I think that some of our friends in Indonesia say that technology is neither good nor bad. It's how you use it, and it seems to me that that we get a lot of we have a lot of negative sentiments towards algorithmic technology that's used to sell us stuff or to sway voters and all the rest of it. But that same technology can be used as well to understand complex relationships and actually to provide people with options that are real to them that they perhaps hadn't thought of.
In terms of kind of bridging services, to your question on technology, it's not integrated yet, but as we were working with also the food and agriculture companies, they are creating, also leveraging technology to pool and farmers together so that they could sell their produce as an aggregate for better pricing. And we were linking that supply to the demand creation that we were creating in workplaces and schools. And I do see, as Karen mentioned, I think it's a movement, hopefully, that come into play together as an ecosystem, but bearing in mind that there are, I think, as Scott mentioned, a digital divide, and that definitely needs to be addressed. And yeah.
We have time for one more question, David.
Well, actually, I've got two. But
We just have time for one.
all right. Well, I'll keep them short. The first one, Karen, is just the proportion of people that are food insecure. Is that because you are taking people with Medicaid? In other words, what's the population there?
Many of them are Medicaid. I mean, we do support Medicaid members. Though, I guess in our aggregate data, we're not breaking it down by what type of insurance. But my assumption is the most part are.
And then the second, the same question, but now to Jeff. What door did you knock on first to be able to land on the ground in Mongolia to do your work?
I think it really, as I mentioned, it's about local ownership. And as we looked at cities, it was really based on both health authorities and the mayor of the city, and meeting with them to understand whether they would be receptive to such an organization. But I think you also need champions and local implementers who will own it. And we were very fortunate to be introduced and work with an organization that one had a history of both policy and implementation change, and it just kind of melted together.
Okay, we'll take one question from the audience. You've been staying at the microphone there.
Hi, I'm Stacey Vieira. I'm a strategic communications professional, and I also am an MPH nutrition student at GW. And my question was mainly related to what Karen could have brought up. Thanks. So my question is mainly about how does Kaiser's not-for-profit status either give you certain freedoms or present certain challenges when you try and create a PPP?
That's a good question. I think that, being a nonprofit, we are required to give a portion of our revenue back, which is helpful because we have money dedicated to bring to partnerships that we can create with the city and local agencies. Though, I think healthcare in the U.S., we're faced with always the challenge of it's unaffordable for the majority of people in the U.S. And so balancing the community health needs along with the cost to give health care. I think it's a challenge for our members while we serve the larger community. And so I think it's always striking that right balance. But, in the city of Oakland, where we're aggressively trying to deal with homelessness, I think we found ready partners, and it's even in the city as far as maybe making it easier to do some of these initiatives because, the time is right for us to be tackling this challenge.
Okay, let's give a round of applause to our panelists. Thank you.